Please be seated. Okay. So, good evening, colleagues, students, friends. I'm Professor Edina, the Vice-Chancellor Interim at the University of Cape Town, and it's my great pleasure to welcome you to this inaugural lecture this evening, which will be presented by Professor Edina Sinanovic, who is the head of the Health Economics Division and Acting Director of the Health Economics Unit in the School of Public Health, here in the Faculty of Health Sciences. I believe we have colleagues and friends who are online with us as well, so a warm welcome to you also. And let me also welcome members of Professor Sinanovic's family. Great to have you here with us. Welcome. Let me introduce the platform party for this evening's event. So we have Professor Susan Cleary, who's the head of public health, and she will introduce our inaugural lecturer. Then Dr. Lucy Kanema, a senior lecturer in the Health Economics Unit, will offer the vote of thanks. She's seated 3 away from me. Associate Professor Lionel Green-Thompson, the Dean of the Faculty of Health Sciences, will deliver the closing remarks. And 2 away from me, of course, we have our inaugural lecturer, Professor Sinanovic. So, your colleagues and friends, you know, inaugural lectures are really a special event in the life of the university. They mark the ascent to full professorship, and full professorship is the highest academic rank to which one may aspire. And of course, it's one that would be an aspiration for any serious scholar. The appointment to or promotion to this rank constitutes a recognition of the stature of the individual. It's an indication of the high quality and the impact of their work, whether it be teaching or research or both. And as for the process to get there, well, it really is an arduous one, I can tell you. Again, whether one is promoted to the rank or appointed to it, really arduous. The criteria are extremely demanding. And so the rank is all the more prized for those reasons. The inaugural lectures provide an opportunity for us to celebrate the achievements of the lecturer. They also importantly provide an opportunity for the inaugural lecturer to share insights into scholarly work in a manner that would be accessible to a broad audience. So it's an opportunity really to engage with colleagues beyond those who are in one's speciality. And so in that sense, to tell us something about what it is that they profess. By gaining a better understanding of Professor Sinanovic's work in the Health Economics Unit, we also, in that way, will build our understanding in the context of public health, understanding of government decisions with regard to health policy in an environment, of course, of austerity, of reduced resources and ever rising demands. So at Parliament's Health Department budget vote last May, the Health Minister, Joe Patla, reported that the current budget allocation for the National Department of Health had dropped quite precipitously from 64 billion rand for 2022 to 2023 to 60 billion, I should say, rand in 2023-24. This decline is, of course, reflected and is felt all the way through in reduced allocations to a range of programs. So we can imagine the consequences that the general public ultimately will face and have to bear. With her focused research into the economics of healthcare, Professor Sinanovic helps to provide policymakers with the economic evidence they need to maximize the use of such limited resources. So in her lecture, the title of which is Getting the Most Out of Life, Understanding the Opportunity Cost of Your Decisions, she will give us, I'm sure, a glimpse into how such research influences health policy, especially in relation to tuberculosis interventions and the human papillomavirus vaccine. But now let me hand over to Professor Cleary, who will introduce our speaker. Thank you very much.
Good evening, everybody. It is really such a great pleasure to introduce my dear colleague, Professor Edina Sinanovic, as she delivers her inaugural lecture tonight. Before I do so, I would like to extend a very warm welcome to Edina's family, her husband Mark and her son Max. Thank you so much for coming, and to all her other colleagues and friends who are here today and are online. Thank you so much for coming today. Edina has what is best described as an exemplary academic career. With a Bachelor of Science degree in economics from the University of Zagreb in Croatia, Edina moved to South Africa in the late 1990s and enrolled in the brand new Masters in Health Economics. Way before we had a Masters in Public Health specializing in health economics, we had a Masters in Health Economics, and Edina was one of the first graduates from that program, thereby being one of the first people to start this important work of establishing the discipline of health economics in South Africa. After that, she went to complete a PhD in health economics from the London School of Hygiene and Tropical Medicine in the early 2000s, where she deepened her focus on the economics of TB. Since that time, Edina has continued to make substantial contributions across all the key academic functions, from research to teaching to social responsiveness. She has made a really massive contribution, particularly in TB, but in other areas as well. And in terms of TB, she has been involved in pretty much any and all economic evaluations of TB that have been conducted in this country, starting with her seminal work on the cost effectiveness of community-based DOTS, which was published ages ago in 2003, to work on public-private partnerships in TB provision, to work on preventing TB and household contacts, to the cost effectiveness of gene expert in TB testing, to ongoing work on a potential TB vaccine, and many, many others. So really, really providing the key policy evidence needed to make the right investments in this key area of TB. Edina is also an engaged teacher, teaching across the majority of health economics topics. Her impact as a supervisor has been impressive, with more than 40 master's or PhD students graduating under her supervision, and it is wonderful to see many of them here today. Finally, on a more personal note, it is particularly special for me to introduce Edina today, as we've worked as close colleagues, pretty much office neighbors, for the past 2 decades. When I started as a junior research fellow in the School of Public Health in 2001, I worked on one of Edina's projects, which is how I first started to learn the methodology of economic evaluation. After that, when I was the director of the Health Economics Unit, I became her boss. Then she became director of the Health Economics Unit, and so she became my boss. And now I'm the head of school, and so now I'm her boss again. So even though some may describe both of us as a bit bossy, it is a wonderful thing to have such a warm relationship that it does not really matter who is the boss. Congratulations, Edina, on reaching this particular milestone in the academic journey. Colleagues, please join me in welcoming Edina as she delivers her inaugural address.
Thank you, Vice Chancellor. Thank you, Sue. Thank you, everybody, for attending my inaugural lecture. And thank you for those who are joining online. It is my great pleasure to be here today. And I'm going to talk about my academic path from a research assistant at UCT to full professor at UCT over the last 27 years. And I'd like to start by saying that the motivation for the title that I chose for my lecture comes from the fact that we have to make choices in our life, and at the same time, the decision makers have to make choices about how much to invest in healthcare. So being a health economist, this actually gels so well, and the choices that we make in our lives are not that different from the choices that decision makers make, because every choice has a consequence, and every cost has an opportunity cost or benefit forgone. So in my lecture, I'm going to first set the scene. I'm going to place my research in the current context of the health sector reforms in South Africa. Then I'll talk about the work that I love doing, my research. And at the end, I'll give a vote of thanks. And I hope I will entertain you for the next 40 minutes. Economics is the science of choice. And the choices are made on the basis of benefits and costs. This is true for individuals deciding on how many donuts to buy, as well as governments when deciding how much to spend on healthcare. If the benefits of our decisions are greater than the costs, then we should do more of that. And we should provide more of the services that's so beneficial. And if the benefits are less than the costs, we should then provide less of those services. And if the benefits equal the costs, it means that we are doing just the right thing, and we should continue providing the same service at the same level as we had in the past. So, economic cost is what we are prepared to give up to get something. So, the opportunity cost is always something that we compare with the next best alternative. So it's the cost of a resource that we use compared to the next best alternative. Then you can ask yourself, what if leisure is the best alternative? Leisure doesn't have the price, we don't have to pay for it, yet it has a value. And that actually differentiates economists from accountants. Accountants need to have a receipt for every cost in order to show that there was an activity. Economists don't need to do that, because for us, there are no free lunches. Nothing is for free. And everything has an opportunity cost. So if somebody invites you for lunch, a free lunch, it doesn't mean that you're not expected to give something in return, even if it's just your time. So in the light of limited resources, we need to do a lot of priority setting because of the notion of opportunity cost. So these are some examples I downloaded from Google. Should I go and study in order to graduate with a degree, or should I get a job and get a salary? So it's a choice you can make. Each has an opportunity cost. Should I invest in cash or in stocks? Should I go on a vacation, or should I get some training, and so on? But importantly for us, in the health sector, actually the opportunity cost most likely is the most important concept we can think of, in addition to the margin, another very important economic concept. So looking at the health sector, I decided to choose two interesting quotes, which will illustrate my point. The first comes from the father of health economics, Alan Williams, who said that costs of treating one patient always represents benefits forgone by other patients or potential patients. And to ignore costs is to ignore the sacrifices of others. And then late Gavin Mooney said that, or he asked the question, can it be right to bring the hard-headed logic of economics to issues of health and illness, suffering and death? Of course it is, because if we don't, the pain of suffering will be greater than they need be. So all public policy decisions require that the benefits exceed the costs to justify them. And the key point is that setting a healthcare policy is not only a matter of trying to save lives, but a question of how many lives we can save given the resources available. So what decision makers need is a systematic, explicit approach to priority setting that is evidence-based. And here we're talking about health technology assessment. And this highlights the strong ethical basis for ensuring that the interventions defined in the National Health Insurance Health Benefits Package are cost-effective and fair. So the health technology assessment is a multidisciplinary approach to evaluating a new technology. It looks at all sorts of different aspects of that new technology. And the technology can be anything from a drug to a new medical device to a way of delivering intervention to public health intervention, anything that we actually need to pay for. Economic evaluation is an important component of health technology assessment. And this is where my work is. I've taken a copy from this figure from the book, a report published by Wilkinson and Wilkinson. And it's a draft methods guide on how to do health technology assessment in South Africa. And basically, it is currently used by the Essential Drug Program Unit, which coordinates all technology assessments in the country, and particularly in order to perform the selection of medicines to the South African National Essential Medicine List. And where my research fits in this whole big picture of the health technology assessment, is the costs and the cost effectiveness. And this is what I will be talking over the next 10-15 minutes. I'll be talking about the research that I did and the research tools of economic evaluation that I used to answer some of the most pressing policy questions at the time. So these two books are often on my desk. I consult them regularly. I share them with my students. And I'd say that without these books and many other books that were published in the field of economic evaluation, we would be much less wiser in terms of how to go about answering some of these questions. So I've been guided by these books, and I'd say that economic evaluation most likely will feature even more in the years to come. Many of you coming from different disciplines probably don't even think about economics much, but I'm sure that will be the case, particularly in the light of the National Health Insurance debate in South Africa. So economic evaluation is an alternative, is a comparison of costs and benefits of alternative courses of action. So we can compare different interventions in terms of the costs and benefits in order to make some kind of recommendation of whether a new technology should be adopted or not. So the type of analysis that we use is called the cost effectiveness analysis. And cost effectiveness analysis is a method of constraint maximization. And that means that we cannot decide whether something is cost effective if there are no limited resources, if our budgets are not limited. But because our budgets are always limited and resources are always finite, we need to have some kind of a framework to decide how cost effective these interventions are. So this type of analysis is a set of tools to inform decisions when there is an objective of improving some measure of benefits subject to constraints. And that constraint often is a budget constraint. This type of analysis guides decisions about resource allocation in healthcare in general and in the development of the health benefit package in particular. And in the health benefit package design, cost-effectiveness analysis needs to be used across the full range of patient populations and subpopulations that have potential access to care. So finally, my research focus. Over the last 25 years, I used economic analysis as a formal research tool to identify and evaluate interventions that are cost-effective, have a potential to improve health, access to care, and quality of life. So I've done numerous cost-effectiveness studies of alternative, preventative, diagnostic, treatment, healthcare interventions for a number of diseases and devices, but in particular focusing on tuberculosis and human papillomavirus vaccine. So I do love health economics, and I think it's a wonderful discipline. It's extremely useful, and it's extremely applicable because the questions that you ask are relevant and will be becoming more and more interesting in the next couple of decades as the national health insurance and the health sector reform in this country evolves. So now I'm going to talk about my life. So move away from economics. It's probably a bit dry for most of you. So I'm going to talk about how I got here, where I come from, and what I did, what choices I made to become a professor. So this is my academic part. So I was born in Croatia, which is a tiny country, but extremely beautiful. It shares the Adriatic Sea with Italy. These are some images. I was born in Zagreb, the capital of Croatia. But probably the most beautiful city that I love in Croatia is Dubrovnik. And I grew up with very cold winters. I grew up with my mom and my dad and my sister. And this is me on the first day of school. I was a very good academic. You can see I'm smiling. I was happy to be at school. That's probably why I'm still here in academia. Yeah. And I decided to study economics when I was at high school. And the greatest influence was my father, who himself was an economist. And I had no doubt that's what I wanted to do. So I did my first degree, Bachelor of Science in Economics, from the University of Zagreb. And during those years, I actually traveled a lot. Because I was based in Europe, traveling in Europe was easy. I spent quite a lot of time traveling and exploring, and I had great student life. So it took me probably a year longer to complete the degree than it should have. But I took a year out to go to London to be an au pair, and then another year to go to Toronto to do all sorts of odd jobs, which gave me such a wonderful insight into how we as humans operate. And then for my thesis, I chose an unusual topic, the role of investment banks in the US financial system. And the reason for that was that Croatia was going through a very difficult political and economic changes, if not difficulties at the time, and was moving from one economic system to another. And there was a lot of need to do research around building financial markets. So I decided for this to be my topic. And because of that, I was offered a job. So my first job was at the local bank, which is the biggest bank in Croatia, called Zagrebačka banka. And I got a job there, and I started to work as a junior manager. I was like headhunted from the university as a bright student. In fact, there were 25 of us who were asked to come and join the bank to become junior managers, to develop this, particularly the financial markets in Croatia that were, as I said, being quite new at the time. So I worked there for a couple of years. It was in the early 1990s. That is me over there in the office environment. Look at that old-fashioned computer. And I spent a lot of time on the phone. But maybe not all the time, because Croatia was going through the process of privatization of the government facilities, and I was involved in a lot of that. I was in the investment banking division. So I would spend a lot of time on the Dalmatian Islands, privatizing hotels. So that picture in the middle there is a picture of an island that is so dear to me. So I actually had a lot of good time and a lot of fun as a student and as a junior bank manager. So the bank sent me to Maastricht to do a postgraduate diploma in financial management, which was very important for my skill development. And I had a great time studying, and finance, economics, that's really what I was passionate about. And when it was time, so I was gearing up to become an investment banker, which I'm sure I would have made a lot of money if I did that. But then I spent my time on this bicycle, and I really had a great time in the Netherlands, eating cheeses, drinking wine, cycling all over the place, and life was good. So I just couldn't imagine myself going back to the bank and be straitjacketed in that suit, and no, I couldn't do it. So instead, I had an opportunity to come to Africa. So this was the view of Cape Town in 1995. that I took from the airplane, South African Airways, as we were approaching Cape Town. And you see, there is no stadium over there. And it's an old photograph. It was actually bent. And you can, if you look closely, you can see all the way to the Cape Point. So this was my first image of Africa, in fact. I've never been to Africa before. First time to South Africa. But I had an opportunity to come here to join my ex-boyfriend on this adventure. And South Africa was going through the very interesting times. And I thought, well, why not? Let me go and have a look what's going on there and explore the world a bit. So I took 1 year unpaid leave from the bank and was told, you have 1 year off. If you don't return, you lose the job. So sure, I most likely will be back, but yeah, I'm still here. So I actually enjoyed being in Cape Town. I traveled a lot during the first few months of my stay in Cape Town, and I really fell in love with the people and the place, and I thought it was wonderful. Is this really Africa? But Cape Town, as it is a really melting pot of so many cultures. But I then wanted to stay longer, and I didn't know how, and obviously couldn't get the job. I tried, but no ways. I was turned down. So I decided to, for a month, to volunteer in Sankob. So I took some time to actually look after these poor birds that were drowning in the oil. There was a huge oil spilling off the Cape Town coast at the time. So I went to the Sankob and I cleaned the birds, fed them, and later on I helped the people from Sankob to release these birds into the ocean. And that was wonderful. But then for me to stay in Cape Town, to continue staying in Cape Town legally, I had to do something. So I knew what I was good at. I was good at studying. I knew what my potential was. And I thought, okay, let me go to the University of Cape Town, see what they have on offer, and I may actually choose to study here. So suddenly the sun shined for me because I went to the School of Economics. And who was there? Oh, Mary Librand welcomed me to the School of Economics, and he said, you would like to study here? You'd like to do Masters in Economics? Please join us tomorrow because the class is about to start. It was January 1996. So I registered for a Masters in Commerce and Economics, and there was also the most helpful administrator, Paula, who still is there, I think. So I started my studying in economics there, and as a student I wrote my first academic paper for the budget project called Privatization in South Africa, Cost Benefit Analysis. I don't have a copy of that paper, unfortunately. And during my days at the School of Economics, I met some wonderful colleagues, and I'm still very much in contact with, including Ravina Jacobs, who is our health economist at the University of York. While I was a student at the School of Economics, I obviously also wanted to and needed to make some money. I applied for a job as a research assistant at the Graduate School of Business, UCT. And I worked for Professor Mike Morris, who is a professor of entrepreneurship and industrial marketing. And I shared an office with him in this beautiful building at the waterfront. And I helped him write a book called Entrepreneurial Intensity. And he wrote a little note there for me, and I still have this book on my bookshelf. I learned a lot from Mike Morris, and that I think set me up for a life of an academic. And how about this? What a chance I had to meet Nelson Mandela. So as a UCT student in 1996, on my way to UCT, on my way to the class, early in the morning in Rondebosch, there was some commotion outside the CNA shop, and I saw Mandela. And he was signing his book that he just published, Long Walk to Freedom. And I was there at the right time, in the right place, and look there, we shook hands. This lasted probably 15 seconds. And what Madiba asked me was, where do you come from? I said, Croatia. And he said, I hope the people of this country are treating you well. And I said, so that's the highlight of my years as a UCT undergraduate, master student. Then Val McIntyre appeared. One day she came to the campus, School of Economics, together with Joseph Kirigia. And they wanted to give a presentation to the economics master's class. And they said, well, we're setting up this new master's in health economics, and this is what health economics is all about. Why don't you come across to the School of Public Health and do this master's rather than what you're doing there? And we listened, and I thought, well, what should I do? I mean, it sounds interesting. And then my mum was there, and my mum is a professional nurse. And I always had this exposure to health. So I had my dad as an economist, my mum as a professional nurse. So perfect match, health economics, why not? So I packed my bags, left the School of Economics, came to the UCT Health Economics Unit, School of Public Health in June 1996. So instead of getting a master's commerce in economics, I graduated with MCOM in health economics in 1997. And my thesis topic was a cost analysis of community-based distribution programs and clinic-based services, contraceptives in selected areas in Kalicha. Quite a wordy title. But what I did, I actually spent a lot of time in Kalicha. And I worked with Di Cooper and Amy Marks on this study that was funded by the PPASA. And we needed to look at how we could incorporate the community-based distribution of contraceptives into the primary healthcare services. So I did this as a part of my thesis. I did this costing study, and I found that having community-based distribution, meaning community healthcare workers distributing contraceptives door to door, was very much cost saving. It was very cost effective. It increased contraceptive use, and it should become an integral component of the health system. That was our recommendation. And not to forget that what we were trying to achieve with that is that we should be looking at the margin, which is not to displace the nurses doing the job already, but just to say, what is that marginal cost that we could pay for in order to get better service, in order to increase the contraceptive use? Why not look at the community healthcare workers and free up the nurses to do something that they're trained for? And then I would say the highlight of this project for me was meeting a late Ivan Toms, who was the Director of Health, Cape Town at the time. So now we're talking 1996, 97. And he said, absolutely, I like the approach. The community healthcare workers should be integrated into primary healthcare and help with the family planning services in places like Khadija. So very soon after that, there was a debate all over the world, particularly in the developed countries, about the role of the private providers in the healthcare services. Should the private providers play a greater role or not? So Di advertised for the job, and there were a couple of people who applied, and I got it. I got the job to work on this particular project called PRICON, and that was my initiation into real life of a health economist. And I'd say that I met some wonderful people through this project. One of them, Lucy Juleson, is sitting right here in front of me. And then Helen Schneider, Harun Vadi, and Natasha Palmer, and Mills. So I worked with this wonderful group of individuals over a couple of years on this project that looked at the performance of involving primary healthcare providers in the provision, obviously, of services for the public patients. And we evaluated their services from the obviously cost and quality of care perspective. And we found that basically it's very difficult to compare the private with the public straight, because the setup is so different. And that we need to check how the private providers would behave if they were contracted out, as opposed to just providing a service on a fee-for-service basis, which was the case at the time, or simply providing services to the public patients on a different kind of provider payment mechanism. So this study actually was one of the first studies that looked at the how efficient the private sector providers were. And we looked at the part-time district surgeons, the primary care chain clinics, and so on and so on. So this was my initiation into health economics. And so this is me in 1998, 97, 98, working in these clinics, collecting cost and utilization data. Then the next project was a very interesting one, and I did the work for the National Department of Health. And during those days, again, late 1990s, there were huge budget cuts, like there are now. And critical care hospital management needed to decide what to do with spare capacity. Because of the budget cuts, they obviously had to cut down on the service provision, and they needed fresh income. So I did this research to show what should be done and how we could actually gain some money or get some revenue from using these public services and facilities. And the recommendation was to lease them out to the private sector. And then today, what we have there, we have the UCT Private Academic Hospital. So those were the beginnings of the Netcare UCT Private Academic Hospital. Now we come to my passion, which is tuberculosis. And TB was not really discussed much in the late 1990s because it's really not a problem in the developed countries, but it continued being a huge problem in South Africa in particular. But in the late 1990s, there was this new idea and support from the World Health Organization about involving the community in the provision of TB care. So I was part of this big study, and I met these wonderful people who I still am in contact with: Catherine Floyd, Lyndon Dudley, Virginia Azevedo, Leitria Grant, and Dermot Maher. And we worked on the cost and cost effectiveness of community-based care for TB in Gugulethu. And the community-based care was provided by the NGO called TB Care Association. And they worked with clinics, and they supported the patients in their communities. And we found that the community-based care was cost-saving and was much more cost-effective than just clinic-based provision of TB treatment. And we did that from both provider and health and patient perspective. And this study led to a national policy on the remuneration of community healthcare workers, and I'm very proud of this work. This is my, I think, most frequently cited paper, and it's actually my first paper. because this is the first cost-effectiveness analysis of alternative approaches to the provision of TB treatment in South Africa. And studies like this one promote improved efficiency, contribute to equity by improving access and reducing the financial burden of care on households. At the time, there was a lot of debate about health sector reform in the developed countries. What must governments do? And there was this whole debate about purchaser and provider split. The government, yes, should pay for the services, but the government doesn't necessarily have to provide them. So how do we go about this purchaser-provider split? How do we go about the contracts between the government and the private providers? So there was a lot of debate, and this is a really great book that inspired me. And at the same time, there were a lot of initiatives to see how the private providers could be made to work for the government and those in need of good quality care in low and middle income settings like South Africa. So this book was very instrumental, as well as these three publications, WHO publications at the time, talking about how we can involve private practitioners, how to come up with a public-private mix in the provision of TB services. And all that combined made me decide what I wanted to do for my PhD. So Diane McIntyre said to me, well, Edina, you're thinking about doing a PhD. I have funding for you to do a PhD on malaria. There's this new drug that is extremely effective. And why don't you do cost-effectiveness analysis of this new drug in Africa? Funding is there, just go and do it. You can register now. And I thought, no, I'm not interested in malaria. I don't even know what malaria is. I want to do something on TB. There's so much going on. And I already was passionate about it. So I designed my own research study. I decided these are the questions that I want to answer. And I want to do it at the London School of Hygiene and Tropical Medicine. But what helped me get into the school is the links with people like Anne Mills and Lucy Gilson and others. What also helped me, and I'm indebted to them, was a generous fellowship from the TDR, Tropical Disease Research, which is linked to WHO. So they paid for my cost to do a PhD at the London School of Hygiene and Tropical Medicine, whilst based in Cape Town. I had a really great supervisor, Liliane Kumaronaike, who led me through the process of my PhD research. The topic that I chose was tuberculosis treatment in high TB HIV settings, evaluating public-private partnerships in South Africa. I got my PhD in 2004, and as a bonus, I was also awarded a postgraduate diploma in public health and policy. So we were the lucky ones. At the time, the London School decided whoever does a PhD this year or graduates with a PhD this year is going to get this diploma. But the PhD needed to be in health economics. So that was a lucky one. So I can add that to my CV, although I didn't do anything about it. So what did my PhD research show? It showed that public-private partnerships are actually extremely important if we want to increase the provision of healthcare services in South Africa. Now more than ever, we need to think about public-private partnerships because they have the capacity, they have interest, and the public health sector needs extra resources. And then I'm talking 20 years ago, so my research has shown the same. And I think going forward, we should be revisiting these messages. So these are my publications. And I'll just tell you one story from my work, from my research during the fieldwork time as a PhD student. And that was when I was working I was looking at the healthcare services provided by the mining companies, the platinum and gold mining companies, because they provide TB services to their workers. And I was doing my interviews with the medical doctors in those mining companies' health services. And one morning, one of the doctors said, "Well, we take care of the patients who are in prisoners, and we go to prisons and we treat them for TB. Would you like to come along?" And I said yes. I just said yes. So I jumped into his huge 4x4, and he took me to this prison. I've never been to a prison before. And he took me to the health services where these there were hundreds of prisoners, TB patients, queuing up for their TB treatment. It was not a nice scene, I can tell you, but again, it just showed the other side. And yeah, so I often remember that, and how difficult it must be for healthcare providers these days, and even then, and these days in particular. So finishing my PhD, returned to Cape Town to work on a study called Protest, which was during the time, obviously, the TB HIV epidemic was a big problem in South Africa. So not only that TB has always been with us, but now we have this TB HIV epidemic. So we looked at what kind of other services should be offered at the primary care level to improve the TB and HIV prevention and care. So our study found out that voluntary counseling and testing using lay counselors and rapid HIV testing is a cost-effective intervention to prevent TB and HIV, and that IPT, which is a preventative treatment for TB, is a cost-saving intervention that should be offered at all primary healthcare facilities for HIV-positive patients. I worked with Harry Hasler, Pren Naidu, Lilani Kumaranaike, and Peter Godfrey Fawcett from the London School of Hygiene and Tropical Medicine. And our results prompted the National Department of Health to include protest interventions as part of the comprehensive package of care for people living with HIV linked to provision of antiretrovirals. And our study also initiated that, helped the WHO modify and update their guidelines in terms of the integration of TB and HIV services. So another very interesting project. We do ignore children often, particularly in TB. There isn't much to do, but these days more than then. So I was offered this wonderful opportunity, which I took, to look at the cost effectiveness of different strategies to prevent TB in child contacts in high burden settings. And I worked with Anna Mandelakas and Anneke Hesseling from Stellenbosch University to see how should we go about preventing TB, latent TB in children. So we developed our models, we ran our models, and our conclusion was no need to screen. Just give those children IPT. That is the most cost-effective intervention. The drugs are cheap, no many major side effects. Testing wasn't working at the time well, although there were, and there still are a couple of different tests. Just give children IPT. And that was in line with the WHO recommendation at the time. So we confirmed the WHO recommendations. And then there is a big trial that we actually were part of for a number of years. And those were the years that I would talk about now, thinking it was 2000 and probably 14, when Gene Expert, a new molecular diagnostic tool for diagnosing TB, particularly TB that is rifampicin resistant, was made available. The South African Department of Health purchased the Gene Expert and actually scaled it up. So Gene Expert was available everywhere. But then we were asked to do an evaluation, which obviously not actually a good idea to do an evaluation of a new technology after it's been introduced. You do an evaluation prior to anything being new in the system. In any case, we did the evaluation, and it was funded by the Gates Foundation, and we worked with colleagues from the London School of Hygiene and Tropical Medicine, Anna Vassal, Alison Grant, and then from the HUU, Nicola Foster, Lucy Kunama, and Lebagan Rama. And what we found was that Gene Expert does not reduce the number of TB deaths. So there's no difference between microscopy and Gene Expert, as you can see. The same number of deaths were prevented using Gene Expert and microscopy. And our conclusion was the incremental cost effectiveness of this particular diagnostic tool might be fundamentally affected by real world issues, such as critical treatment practices. What do actually nurses and doctors do on a daily basis in terms of their guidelines? The treatment for HIV was not available to everyone, and most of those people who were recruited in our study were actually HIV positive without them knowing they were HIV positive, and they were not on HIV treatment. And we recruited around 4,000 patients in this trial. And lastly, there were issues with obviously provider and patients' adherence, which is always the case. So we didn't show much, but maybe we did. We showed that regardless of diagnostic tools, it may be the latest state-of-the-art diagnostic tool that we may have. If health system is not there to support it, it's actually probably a waste of money. But I think rightly the Department of Health decided to keep the gene expert in place. We did not disinvest from it. We continued using gene expert, and these days there's also gene expert ultra, and there are other tests coming our way. But our study has shown that there's more to play than just a new technology. And even more importantly is the cost to the patient. So Nicola Foster and Lebegan Rama, both PhD students in the Health Economics Division, did their work, or part of their PhDs were to look at the economic burden of TB on households and patients. And they found that indirect costs accounted for 52% of total cost, and these indirect costs are income losses. And the greatest share of these costs, almost 41%, was incurred prior to starting treatment, with the largest portion of them being due to income loss. And another horrible finding is that access to government social protection mechanisms seem to be a challenge for most patients, particularly during the intensive phase of treatment, when these costs are actually incurred. So what we found out, and what we thought the biggest policy relevance from these two studies, was that TB should be diagnosed as early as possible, obviously, to minimize these costs to the patient. The support while on treatment in a way that minimizes income loss. How can we support patients so their costs reduce? And lastly, social protection to those with the lowest income. So we're talking about, again, disability grants, how to get them to those who need them. At the time, South Africa was moving away from hospital-based multi-drug TB treatment to clinic-based multi-drug TB treatment. So our colleague Lebegan Rama and Helen Cox were the key people involved in the studies looking at the cost of decentralized model of the provision of rifampicin-resistant TB treatment. And they found that it is a cost-saving approach. Why treat patients in a hospital setting? Unless obviously they're extremely ill, but if they're not very ill and if they can be treated in the community, that should be done at the clinic level. And then the next step, again, in line with the MDR-TB, is that a new drug, bedaquiline, was obviously available, but extremely expensive. So we did a study, or actually a PhD student of mine, Kate Schnippel, did a study on the use of bedaquiline for the multi-drug-resistant TB, and she's found that obviously it is more cost-effective, and that despite the high price of the drug, the cost of reducing the hospitalization costs in particular would offset the high drug price. However, these drugs come with severe adverse drug reactions, and more studies were done to look at that, and we found that if these severe drug reactions were minimized by different drugs or different combination of drugs, then they could improve cost effectiveness even. And now this is probably the lowest moment in my academic life, and that is I had a PhD student, Tanya Kasten-Hilke, pictured here, who completed her PhD looking at the health-related quality of life in TB patients, and she sadly passed. She sadly passed away literally a month after she graduated with a PhD. She died of breast cancer. She was very young, and that was very sad for me as a supervisor. But I celebrated her achievements, and in fact, together with her supervisors from the Basel University, we published her last paper that she didn't manage to publish. Whilst alive, we decided to publish her paper and to get it out there. with her as the first author. It was quite challenging because the reviewers asked us to revise the paper using different kind of data, which we didn't have. So it took us quite a long time. Probably the most difficult paper I wrote together with my colleagues was this one. But I'm so happy we did it. And it's important for her son to have this kind of evidence. And what her study found is that the greatest improvement in average mean score from baseline to 6-month treatment, TB treatment, was observed in mental health. So in other words, TB patients obviously had difficulties in their daily functioning, particularly in relation to mental health. But if the treatment was given in the right time, and adherence was obviously the one that we would like it to be, the mental health was impacted the most. Not just that the patients were getting better and being cured from TB, but also in terms of the quality of life. The impact of treatment was greatest on the improvement of their mental health. And we think that the management of TB should also include services that focus on mental and psychosocial needs of the patient. And that is actually becoming more of a discussion these days, not just in TB, but also in other chronic diseases. And we are actually doing some similar research looking at that. And now the hottest topic at the moment in terms of TB is vaccines. Because vaccines are considered to be one of the best investments in public health. We did a study that looked at the cost effectiveness of a potentially effective vaccine, TB vaccine for infants called MVA-85A. And the idea was to add this vaccine to the BCG vaccine to infants a few months after they were given the BCG vaccine. The study went into the clinical trial, and at the start of that clinical trial, we developed our cost-effective model. And we were sitting there waiting for the efficacy trials results to come out. So the results of the phase 2B trial phase of the trial came out with the vaccine being only 17.3% efficacious, which meant they had to stop the clinical trial because of huge costs. The vaccine was obviously not effective, not efficacious. And we obviously had to plug it into our cost effectiveness model to find out that this vaccine obviously would not be cost effective. Nevertheless, we published the work because we developed a really good model that could be used if in the future a new infant TB vaccine is developed. This is the kind of model that could be used and replicated by others. But we also found out that if this vaccine had an efficacy of at 41.3%, it would be considered a cost saving. And maybe then it would have been another vaccine available. But it didn't happen. And what also happened at the time is that because of the failure of this and many other vaccines that were being developed for infants, a decision was made both by the WHO and the major funders, investors in TB vaccine development. The development of TB vaccines should move away from those that focus on children to those that focus on adolescents and adults. Because adolescents and adults are those who get sick more than the children. They're those who lose income if they fall sick or if they die. And in any case, we have a BCG vaccine for infants, for children. They will not die from meningitis and miliary TB because they would have been vaccinated. But adolescents and young adults would. So now there's a shift in terms of the TB vaccine development from childhood vaccines to adolescents and TB vaccines. WHO published the manuscript recently called An Investment Case for New TB Vaccines, and showed that TB vaccines are highly cost effective. So there are a lot of modeling studies that have shown that they're highly cost effective, in that for every dollar invested in a TB vaccine, we get $7 in return in health and economic benefits of a 25-year period. However, vaccines are not easy to develop, and currently there are 17 TB vaccine candidates under active clinical development. And there is one that is actually entering the phase 2B trial in South Africa and many other countries, but including South Africa. And fingers crossed, it may be the one. However, there are many challenges in developing new TB vaccines. There are issues with which biomarkers to use. There are also issues with the fact that there's not much investment in TB vaccine development. There's more investment in other, I think 1% of investment is invested in TB vaccine development compared to, so 1% of the investment that was invested in the development of COVID-19 vaccine is currently being invested in the development of new TB vaccines. And lastly, obviously, we need the right political environment to be interested in this kind of thing. To use economic evidence most efficiently, we need to develop standard methods and approaches to doing these types of analyses. So for a couple of years, we were involved in this consortium, Global Health Costing Consortium, which focused on developing the tools that would be used by others in conducting exactly these types of analyses worldwide. So we developed a reference case for estimating the costs of global health services and interventions, and we developed a costing guidelines for tuberculosis interventions. And I must acknowledge Dr. Lucy Kuhneman, who was probably the most important person in development of these two, together with our colleagues from the London School, Anna Vassal, Sedona Sweeney, and Carol Leving, for example. But many others were part of this consortium. And I think these resources are extremely useful, not just for South Africa and not just for TB and HIV, but also for other interventions. And also perhaps what to make out of it is that accurate and up-to-date cost data can inform decisions around healthcare financing and strategic purchasing, and can be used for setting the reimbursement rates under the National Health Insurance. So I try to bring my research always to the National Health Insurance. Now I'll just shift the focus a little bit and just briefly talk about the HPV vaccine. As you know, the HPV vaccine is available in the public sector, and girls age 9, 10 are given the vaccine free of charge in order to prevent the development of cervical cancer later in life. This vaccine was developed in 2014, was made available in South Africa in the private sector at the cost of $120 a dose. And we needed 3 or 4 doses for protection. So we got funding to look at the potential cost effectiveness of this vaccine, in addition to the cervical cancer screening program, to see whether this actually would be a worthwhile intervention if the price was reduced dramatically. So we developed a model, a cost effectiveness model, and looked at different, obviously, price levels, and came up with a price of the price should have been reduced by at least 60% for the introduction of the HPV vaccine to the screening, together with the screening program, for it to be a cost saving. In other words, the vaccine together with the screening would save more lives, and there would be the same cost. But the vaccine at that price was absolutely not affordable. So what we also did was something called budget impact analysis. So if we were thinking of scaling up the introduction of the vaccine, we would obviously need to look at what impact it would have on the, if the price was reduced, what impact it would have on the budget, because the demand would be huge. I think at the time, and still there are probably 5 million girls of that in that age group. So we did the budget impact analysis, and we played with different price levels, and we actually reduced the price even further down, from 60% down to 90%. And we concluded that if the price of the vaccine was reduced from 90%, it was reduced by 90%, that to vaccinate all the eligible girls, I'm talking 5 million girls, at the time would be 0.75% of the total budget, or total spending on health. But obviously at the time, that was huge amounts of resources. Where would the money come from? we would either have to raise the taxes to get more in the budget or reallocate the available resources from another program and take it to the cancer or HPV prevention. So that didn't happen at the time, but our studies have helped decision makers become stronger in their advocacy as well as their negotiation with the pharmaceutical companies to reduce the price not only by 90%, but by 96%. And at the price of $4.6, I don't know what the price is right now, but when the vaccine was introduced in 2014, the price was around $4 per dose. A huge reduction in price. And the government obviously decided it was an important investment, it can save lives, it can save and minimize future costs of treating cancer, cervical cancer. So this is a really happy story, and I really hope that the vaccination, HPV vaccination, continues in South Africa. At the time, I was invited to be part of the WHO strategic panel around the HPV vaccine introduction in different countries. So I worked with Mark Jett and Raymond Futabesi, Mark Jett from the London School and Raymond Futabesi from the World Health Organization, on developing the right model for different countries that would consider implementing or introducing the HPV vaccine in their health system. And we found that actually the HPV model is not that difficult. It's a very simple one because the HPV vaccine would be given to girls to prevent cervical cancer later in life. The model has become quite more complicated these days because we also thinking of perhaps vaccinating boys. In fact, boys should be vaccinated, but not in the public sector yet. That's not really something that's being done. But hopefully the policy will shift in that direction and the boys in South Africa will also get the HPV vaccine. There is sufficient evidence after 10 years of this vaccine being administered all over the world, except a few countries that are suspicious about it. And we know the reason why. So 10 years later, we have sufficient evidence that the vaccine saves lives. It reduces the number of HPV infection. It reduces the number of cancer cases, and the price is down. So it should be implemented wider. And in some countries like Kenya, they've just published a study showing that you actually need one dose to be fully protected. So one dose at $4 a dose. What a good buy. And that's the word that we use in health economics often. Is it a good buy? And I think $4 per vaccine, plus obviously some admin costs, healthcare provision costs, to actually save future costs of treating cancer and save lives. Now we come to the most interesting project that I've been involved in over the last probably decade, and that's me moving away from tuberculosis into different kind of brain, and that is sexually transmitted infections. And our research is always interdisciplinary. We cannot work on our own. We cannot just do research on our own. We need to work with individuals from different faculties, departments, disciplines. So our colleagues from IDM, the Division of Virology, and others developed this new diagnostic tool called GIFT, Genital Inflammation Test, which has been patented for, I think, biomarkers in South Africa and in the EU. And currently we're running a clinical trial. And this is a test that potentially can detect genital inflammation, which is a precursor for STI and HIV infection in asymptomatic women. So it's women who don't have symptoms, but who have either genital inflammation or an STI, and who are not given treatment because they're not aware of it. So this very simple, rapid point-of-care test could be a game changer. The time will show. So 7-8 years ago, Joanne and Lindy came to the HU and asked if we could collaborate on the project with them. We decided that was a good idea, so we made some good choices. The funding came generously our way, and we did some interesting preliminary study around this test. And I had two bright master students who did their research around the gift the gift device. They published their thesis, and they produced some interesting results showing that the gift device would be extremely cheap in the routine setting and extremely cost effective compared to syndromic management of STIs, which is the current practice in South Africa. And even more cost effective than Gene Expert that is currently being used, and actually unaffordable. So there is this clinical trial taking place right now as we speak in Madagascar, Zimbabwe, and South Africa, where we need to get the real evidence on whether this gift device is effective or not. What is its specificity and sensitivity, and how can it be integrated in the clinical guidelines for STIs? So watch this space. This beautiful picture shows the researchers, including myself, doing just one small segment of this big study. And we're only focusing on the cost effectiveness and the budget impact of this test if it's proven to be effective in the real world. There is a website there if you're interested to learn about it. Linked to this gift clinical trial, there is another clinical trial currently taking place. And the economic side of this is led by my dear colleague, Sue, who asked me to join the team, which I gladly did. And Amaraj Obzek, who is also here with us, our colleague from the HU, together with Remco Peters from the Foundation for Professional Development. And this clinical trial is actually looking at the STI screening and treatment in pregnant women in order to prevent preterm birth and low birth weight. Yeah. So if the clinical trial finds that all pregnant women in South Africa should be screened for STIs, and we find that it's not very costly, it's actually at the margin, just a small fraction that could be added. And it's cost effective in terms of avoiding premature births and low births. Then we have another set of tools that can actually help so much that with a little bit of extra cost and the resources that you already have, because the nurses are there, community healthcare workers are there, we can make best use of them. Maybe we can make this world a better place. So over the last 25 years, what I've learned it using a two-perspective approach in economic evaluations. And that's the one that incorporates both the healthcare as well as the patient perspective, may result in a much better decision-making. I've also learned that disease-specific priority setting is limited. We need to look at the system and population-wide approaches to disease prevention, screening, and treatment. Up to now, I've been actually only focusing on one disease. Health systems constraints, such as human resources, also need to be reflected in our cost effectiveness analysis, not just the budget constraint. And this is very important because our health system is the one that can impact on ultimately what we do in the health sector environment. Not just the new technology, not just even the money, but it's how the health system implements these interventions. Do we have enough healthcare resources, and what level of healthcare resource should be used for different interventions? We don't need doctors to provide contraceptives, and so on. And lastly, we should actually pay much more attention to different types of cost effectiveness analysis, and that's called distributional or extended cost effectiveness analysis that incorporates the equity and poverty reduction in this framework by including the non-health benefits. just the health benefits, but the non-health benefits. And they focus on financial risk protection. So, to conclude, economic evaluation is critical for national health insurance. And what we need is a national level funding plan to develop a health technology assessment institutions to support national health insurance. We also need the robust data systems to support the efficient functioning of such institutions. We need mechanisms for cost data submission using standard methods. We have to update data regularly to inform assessments and policy decisions. We need to continuously raise awareness of the importance of using local cost data. Lastly, we need to train more health economists and disease modelers. And I'll finish my presentation by showing a really nice summary of what I think is important currently in my research and generally for all of us using data in our research all the time, which is from late Hans Rosling's book called Factfulness. And he says that effect-based worldview is more comfortable. It creates less stress and hopelessness than the dramatic worldview, simply because the dramatic one is so negative and terrifying. When we have effect-based worldview, we can see that the world is not as bad as it seems, and we can see what we have to do to keep making it better. What will I be doing in the future? More of the same, which is using economic evaluation that has the potential to influence policy. I'll continue mentoring and supervising masters and doctoral students, and I'll continue building research capacity of junior research. Now, the last is actually the easiest and actually the most comfortable and the fun part is to say thanks to people who I would like to say. So the big thank you goes to Emeritus Professor Diane McIntyre. She was instrumental for me to be here today. So I'd like to thank you, Di, for believing in me and particularly for accompanying me to the Home Affairs Office to say to the officials that she needs me and in the HEU, and that please could they give me a work permit. And they said, okay, yeah, they asked me a lot of questions, which I was able to answer satisfactorily. And they said, okay, we'll give her a work permit. But they looked at Di and said, what after we give her work permit, she leaves the health economics unit? What if she just disappears? And Di said, I will break her kneecaps. Very typical of Di, isn't it? So Di, that's the reason why I'm still here, probably. Then I'd like to thank my colleagues from the health economics unit that I worked with since 1996. There's a long list of the colleagues who came to the unit, who left the unit, who are still working at the HEU. So you can read the names, but most of my colleagues currently working in the HEU are here present. So thank you all. Thank you all for your collegial approach to our life at the HEU, for being wonderful colleagues. I just feel like HEU is my second home. It is my intellectual home. We have great time at the HEU. We have parties, we cook food. Thanks to Vanessa today, this morning, we had the banquet. And we take the time to celebrate achievements, to celebrate colleagues giving birth to babies, getting married, publishing a paper, and so on and so on. I also would like to thank all my colleagues at the School of Public Health, because the HU is part of the department. I think it's a nice bunch. Then just a list of colleagues that I've worked with over the years. And my PhD students, I learned so much from you. My master's and postgraduate diploma in health economics students. And lastly, I'll look at some of the more personal side of vote of thanks here. I'd like to thank my mom and my dad for installing the right values in me and my sister. And they asked me to always being not just honest, but in whatever I do, that I show a lot of integrity. And for me, that is the biggest value that I carry on. Is my parents visiting South Africa in 1998, when my dad was still alive. He's not alive, he's not with us any longer, but he is very much alive in my heart. I'd like to thank my sister. Always sisters, forever friends. I've learned so much from you too. And thanks to my sister's family for just hanging around and being good company. Then my South African family, I'd like to thank my father-in-law and my late mother-in-law, who welcomed me to their family with open hands. This is them visiting Croatia before my son was born. It was 2000 and June 2005. And I also like to acknowledge my sister-in-law, Kim van Diemt, who sadly died too young. But I've also learned a lot from her about life and commitment. And my very special South African friend, Dawn, who helped me so much in the early years of my life in Cape Town. We had fun traveling around. And lastly, my own family. My husband, Mark, who I've been married to for 20 years. And our son, Max, who I would say is probably the best thing that happened in my life. And I would like to thank my husband, Mark, for helping me raise Max and watch him grow into a very fine human. And guys, thank you for being such a fun at home. And thank you for being cool and for inviting me to watch all those soccer games on Sunday afternoons and supporting West Ham, the best team. And thank you, everybody, again, online and in person, for coming to the inaugural lecture. I really enjoyed it. And again, thank you very much.
Thank you very much, Edina. I'd like to call now on Dr. Lucy Kanema of the Health Economics Unit to deliver a vote of thanks. Lucy.
I probably get the best role tonight. Thank you so much, Edina, for sharing these important parts of your life. Thank you for sharing about your work and about your family and everything that means so much to you. Edina and I first met in 2010 when she taught me economic evaluation, and she still continues to teach me economic evaluation. Edina is a really dynamic teacher who easily engages with her students. She has a deep, clear understanding of the theory of health economics with a strong foundation in pure economics, which allows her to go back to first principles and explain concepts really well. Edina has a real passion for assessing the economics of tuberculosis and vaccine development, which I think is quite clearly demonstrated today through her work. And as Sue mentioned, she was actually the first master student to graduate, or one of the first, from the Health Economics Unit. So here's a picture of Edina. and a beautiful door. And this image is something that I often think of with Edina, because when she first asked me to come to the health economics unit, she said to me, some people come through a small door and some people come through a big door, but you still can be inside the health economics unit. And she offered me a position as a research assistant, and I took that role for the Extend project. And I used to think that I came through the small door, but I'm starting to think that actually maybe I came through a door as beautiful as this in Zanzibar. Edina then went on to be my PhD supervisor, and she's really the type of supervisor who holds you to account. She expects you to work independently, but she also handles you with an immense kindness. She's also the supervisor who you can visit at home. You can visit her on your graduation day, during lockdown. Maybe you can even have dinners together, and she'll buy us some Prosecco and we'll enjoy the evening. To me, Edina exudes this style. She has Croatia in her blood, and she is so proud of her homeland, but she's also South African. She has the Adriatic Sea as a memento that she carries with her, and she has a lot of beauty and simplicity, whether that be within her work, within her teaching, or within her surroundings. She really is a minimalist, and I've often had to forward her emails because she deletes her emails. She's also very confident. She has a classical style. And to me, this is also something that's full of a lot of class. She's very meticulous and ordered, and she likes things to be in a particular way. I also think of her as quite stylish, but the thing that really stands out for me is Edina's warmth. She is a very warm, loyal, and very authentic person. So for me, Edina shows this warmth and her joyfulness. She actually loves very deeply. She especially loves Max and Mark. And Edina, your mum must have been so proud to hear that you became full professor and would love to be here, I'm sure. But also your father. I can imagine he would be immensely proud of you. I often hear "Bok Max" down the corridor as she checks in on Max after school. And Edina was one of the first visitors I had in hospital the day my daughter was born. There she was, standing in her clean linen, white linen. Well, I felt like I had just had a marathon, but just such a happy face to have. She is incredibly loyal and fair and principled and direct. And because she has such strong boundaries, it makes her actually very easy to work with, because she reserves enough strength that she can balance these very important parts of her life. And this is a skill that I find particularly impressive. She has an unending commitment to high standards and is a very loyal colleague and friend. And she has been a truly fabulous mentor to me. And I'm very pleased that Max has chosen UCT so that he can study there, so that Edina will be held back in South Africa for just a little bit longer so that we can work together. Edina, your legacy is going to live on. What an absolute honor to greet you as full professor, Edina Sinanovic. Thank you.
My role is just to round up this afternoon's proceedings, but I couldn't help reflecting as I heard the talks this evening about how we've moved from Zagreb to Cape Town, from Maastricht to this place we call Kamerorigais, the place of the stars, as the first people called it. But interestingly, in the story of migration, Edina, you spoke about this falling in love with the people of Cape Town, and I think that's an easy thing to do. But I think Cape Town's that quintessential space where the telling of stories makes us that melting pot of nations and of peoples from all over the world. and makes it a richer place for that. I want to just acknowledge Mark and Max in this evening, because it's not often that we celebrate a moment like this with families in the house. And I'm not always sure that families have the true measure of the depth of contributions that the scholars amongst us make to how the world looks after they have dealt with it. I was also quite excited to see the work on UCT Private Academic, because we're about to have a conversation in regard to that place now that refreshes the thoughts that you had in what you presented here. But I think this evening has really been a celebration of how our decisions often coincide with the people that we meet and the connections that we make, because life is like that, a continuous journey of decisions along the way, connections that we make, and every now and again making a substantial difference in the world. And so thank you for that, and thank you for that very story-like reflection on an extremely important academic career. Colleagues, it remains only for me to invite you to refreshments upstairs, but thanks again to the VC who's been with us this afternoon, to Sue for presenting the candidates, and to Dr. Kanema who joined us this afternoon. So thanks very much, colleagues, and if I can ask you to stand as the procession leaves, please, and then join us upstairs.